So, have your seats, please. Today we'll have our first lesson on neoplasia. We'll give some terms in the beginning. What's the difference between neoplasia and hyperplasia? And what is the similarity? In both lesions, there is a cellular population which grows. However, in hyperplasia, this is under control, meaning that when the stimulus is away, the cells come back to their normal level of proliferation and apoptosis. This is not imbalanced proliferation. On the contrary, in neoplasia, even when the stimulus is no longer present, the cells continue to grow. And the question is, how do they grow? Do they grow with some sort of respecting the surrounding tissues, or do they grow invading the surrounding tissues? In the first instance, we have benign neoplasia. So, as you understand, benign neoplasia is a local lesion. That means it grows in some part of the body, and then, if it is excised, there is no risk of disease recurrence. On the contrary, malignant neoplasia, known as cancer, grows invading tissues. That means it is not a local lesion, it is a potentially systematic lesion, meaning that despite the fact that you can resect the lesion, sometime in the follow-up of the patient, what may appear? What may appear sometime in malignant lesions? Metastasis. So, what are you signing, please, here? Why does it take so much time, I don't understand, to put a signature and live and listen what's the difference between benign and malignant neoplasia? More quickly. No, it's not the official document of the government or the, I don't know. It's just a sheet of paper. More quickly. So, what do we look pathologically in benign neoplasms? First of all, they must be fully excised, because if some part of the lesion stays in the patient, the neoplasm may grow again. Locally, but it may grow again. The cells forming benign neoplasms. We should understand the tissue of origin. That means cells forming benign neoplasms are either fully differentiated, pay attention, I don't say well differentiated, either fully, completely differentiated, meaning that they look just the same as normal tissue. How do you know they come from a neoplasm? If you put it on the microscope, it's normal tissue. You know it from the macroscopic evaluation. It was a tumor, and you put the tumor, take a section and put it in the microscope, and you see a normal tissue. This is complete differentiation of tumor cells. So, benign neoplasms can be fully, completely differentiated. However, they may have some malignant potential, and this is most often shown in the appearance of neoplastic cells. So, if in a benign lesion which does not invade, is a local phenomenon, there is some sort of atypia in the cells, some sort of nuclear enlargement, an abnormal ratio between cytoplasm and nucleus. That means the nucleus grows and the ratio is abnormal. Cytoplasm does not grow because that would be hypertrophia. In atypia, showing a malignant potential, the nucleus grows, but the cytoplasm remains the same. So this is atypia. So how do we call this? If we have a benign population, cellular population, not invading tissues, which, however, has some sort of atypia. How do you call this? This is, you know it? Excellent. This is dysplasia. So, when you see the pathologic term dysplasia, the lesion is benign, even if it is low-grade dysplasia. And what's the clinical significance of dysplasia? If it's a low-grade dysplasia, you do nothing, because it may vanish, and the tissue will be normal again. However, if it is high-grade dysplasia, you should excise the area with high-grade dysplasia, and the margin should be free of dysplasia. However, you do not have radical surgery. You have conservative surgery, because high-grade dysplasia is not dangerous as far as it is fully excised. There will be no risk of metastasis. Are you sure you know these basic concepts, please? Do you think you'll understand them by reading textbooks? You won't. You'll understand them listening to me and communicating with me. That's how you'll understand them. Is that clear? Yes, please.
Benign tumors, before it is contained, the cells over-proliferate, right?
They continue to grow, always respecting the surrounding tissues. However, there is some danger here, because as they grow, they may compress the surrounding tissue. Think of a benign meningioma. It grows, it does not invade, but it presses the brain, so it's dangerous. So, benign neoplasms can have complications, either by dysfunction of the surrounding tissues or by rupture, because if they rupture, then bleeding will occur, and this may be dangerous for the patient. And the third danger is malignant transformation, because some benign neoplasms, especially those with dysplasia, not full differentiation, not complete differentiation, dysplasia can turn into malignant and invade. That's all about benign. Yes, ask me.
Do they still over-proliferate?
Always, yeah, they grow. It's not hyperplasia, it's neoplasia. They grow, but they grow pushing the surrounding tissues, not invading the surrounding tissues, nor their own stroma. These are benign. Now, malignant. How do we understand malignant? They invade the surrounding tissues, and the cells are almost never fully differentiated. They have some degree of atypia in malignant. So, atypical cells, invasion, malignant neoplasms. Then we look for differentiation. That means, which tissue that we know does the malignant cells look like? Do they look like adipose cells? It's a liposarcoma. Do they look like glandular epithelium? It's an adenocarcinoma. Do they look like squamous epithelium? It's a squamous cell carcinoma. So, in malignant neoplasms, we look for differentiation primary to define the histogenesis of the malignant neoplasm and make the proper term in diagnosing. Then we look how much differentiated they are. If they look very close to normal tissue, this is well differentiated neoplasm. If it's so-so, moderately differentiated. This is the grade, the histologic grade. If they look like a normal tissue only focally, and practically we cannot tell with safely which tissue does the neoplasm come from, this is poor differentiation. Grade 3 or high grade neoplasias. Attention, all grades, grade 1, well differentiated or low grade tumors. Grade 2, moderately differentiated or that's moderate differentiation. And grade 3, which is poor poorly differentiated or high-grade tumors. All three grades are malignant. When we see grade, we understand that the tumor is malignant, not benign. In benign neoplasms, we can grade dysplasia, if it exists. All right? When you see grade, it means that the tumor is malignant. And what else do we examine? The stage, which is the most important prognosticator. That means it reflects the survival potential of the patient. So, what is stage? How far has the tumor, the malignant tumor, invaded? If it invades locally, the surrounding tissues and its own stroma, this is stage 1. It's not benign, it invades, but locally. If it has spread through lymphatics in regional lymph nodes, second stage. We have lymph node metastasis. That means the tumor needs chemotherapy, if we define the metastasis. If they have hematogenous spread in tissues far away, the primary lesion, this is end stage. And in this stage, the patient has the lowest survival potential. All right? So this is all you need to know from the pathology, from the theory of pathology of neoplasms. Now, let's have a look here. What sort of specimen is this? What sort of specimen is this now? You have to be familiar with the specimens. What sort of specimen is this? Yes?
Question about the stages.
Yes?
The question is, if it has spread through the circulation, circulatory system, does it mean that it has already spread through the lymphatic system? And the second question,
It's not necessary for the tumor to spread first on lymph nodes and then in distant organs. However, it is most often done this way.
if it's through both, do we classify it as the worst, meaning at stage 3?
If the lymph node metastasis is not regional, but is from a lymph node at a distant site, some staging systems in some cancers define this as distant metastasis. However, this is not the rule, it's the exception. The rule is, if the cancer has spread to regional lymph nodes, the stage is not final. The final stage is hematogenous spread, as a rule. But we won't talk about specific sites now. Yes?
Is most of the time the malignant tumor in the first and benign and then becomes malignant?
It's not always this way. Some tumors are benign and then they are malignantly transformed. However, most malignant tumors grow as malignant, not as benign. This scenario is valid, but in a minority of cases. And we have the malignant transformation of a benign tumor. This is why benign tumors are excised. One of the reasons. Remember the other two reasons why benign tumors are excised? They may rupture and we have bleeding in the patient, which may be fatal. And the other is they compress the surrounding tissues and make them dysfunction. These are the three reasons why a benign tumor is excised. Okay? So here, what sort of specimen is this you see in the microscope? Is this tissue? Is this tissue? Is this a tissue specimen? No. This is a cytologic specimen. And this is a pap smear. That means you take exfoliated cells from the cervix and have them on the slide. So, do you remember how we define atypical cells? Which cellular compartment is of vital importance to define atypia? And pay attention, atypia does not always reflect malignant potential, because if we have some sort of a stressful stimulus, such as chemotherapy, cells may become atypical, but this is of degenerative nature. It's not of malignant behavior. And furthermore, when tissues are severely inflamed, and especially with acute inflammation, meaning that there are many which inflammatory cells characterize acute inflammation, which cells? Who has done the lessons? He wasn't good. He wasn't good enough. Who has done the lessons of inflammation? Don't know the neutrophils. You want me to repeat 4 hours of inflammation? Why? What have I done to you? No. What have I done? And you make me make the 4-hour lesson of inflammation again to understand that neutrophils are the cells of acute inflammation. Why? Anyway, the neutrophils. If there is a tissue it's full of neutrophils, that means it's acute inflammation. Cells become atypical. This is regenerative atypia. It doesn't have to do with malignant potential. So what do we say? If we have a severely inflamed tissue, we say, let the inflammation leave, pass, and then we look at the cells. If the atypia remains, it was not regenerative. It was of malignant potential. All right? So, which cells here in this cytological smear from the cervix appear as atypical? Who can show me? How do we define atypical cells? The nucleus, the big nucleus. The nucleus is big, and the cytoplasm is as it was. So the ratio is increased between nucleus and cytoplasm. So come and show me such cells here that the nucleus appear big. Who can come? Who is to come? You come. Oh, no, there. You come. You come sit here. Yes. So, which nuclei appear big? And the cytoplasm is small. This one. Excellent. So, this is atypia. All right? So, we have atypical cells. And in this cytological smear, we define the atypia as of dysplastic nature. So, this is dysplasia. However, if it is low-grade dysplasia, we'll do nothing. Just follow up. Just watch the region, because it may vanish on its own. If it is high-grade dysplasia, we have to take a biopsy, see if the lesion is neoplastic, of a malignant nature. If it invades, we will think of radical excision, because it's cancer, it has invaded. If it does not invade, so it is high-grade dysplasia, we'll think of a conservative resection, not lose the uterus and the cervix, because these women are young and they want to have children. So we'll have a local excision of the dysplastic epithelium, on condition that what remains in the patient is not dysplastic. Because if we leave dysplasia in the patient, cancer will develop. All right? Yes?
Why do we keep the low grade? Why don't we...
The possibility of a low-grade dysplasia to give cancer is very, very low. It's not impossible. Don't think that cancer always develops on the background of high-grade dysplasia. It can develop on the background of low-grade dysplasia, even on the background of normal appearing epithelium, which, however, is not normal at a genetical level. But we do not see that. Okay? The rule is that high-grade dysplasia gives rise to cancer. That's the rule. There are exceptions. Yes?
How do we differentiate between high-grade dysplasia and low-grade?
Come here. Come here. Now, look at this epithelium. Can you define which is normal and which is not? You look at the architecture, how the stratified squamous epithelium has the parallel layers of cells, and you look at the nuclei.
Okay. So
What do you think?
we can-
With the mouse.
we can
Use the
see
mouse.
that, here in the stroma,
Yeah.
there are a lot of nuclei
Yes.
proliferating.
The nuclei that are in the stroma, are they of epithelial cells? Is it cancer? What are they? They are inflammatory cells, all right? So, leave the stroma.
And here in the epithelium, we
Yes.
can see a lot of nuclei
Yes.
in layers where they shouldn't have been.
Yes, but have a look at the layers here, look here, and have a look at, can you discriminate,
bigger, yes.
yes, can you discriminate here layers?
No.
Here you see the layers, this one,
okay.
these ones, they go in parallel. In this area, however, they've lost their polarity. We cannot discriminate between the layers. They are all together. This is dysplasia. All right? And most often it looks darker. Why? Because nuclei have grown. So they take the stain hematoxylin and they appear dark. Okay. So this is dysplasia. Yes?
Why is the keratin in this plastic tissue more pink?
I can see that, but it does not have to do with the malignant potential. On the contrary, when we see keratinization, this is a normal phenomenon because squamous cells can keratinize when they have a stimulus. So it has nothing to do with the degree or the presence of dysplasia,
Yes, but why is the color different?
because the nuclei have become larger, so it's more dark. And they are many because they proliferate. And do you see here these downward proliferations? Have a look. When these downward proliferations are a bit sharp, this could be a sign of early invasion or microinvasion, as we call it. However, from a clinical point of view, either if the neoplasia is microinvasive or the neoplasia is of high-grade dysplasia, the treatment is the same. What is this treatment? When we have high-grade dysplasia or in situ carcinoma, that means within the epithelial tissue, with no invasion. What is the treatment from a clinical point of view? What do we do? A local excision, not radical surgery. You clear the area, and the margins are dysplasia-free. That's, yes?
You referred to the pointed edge of the...
Yes, if the downward proliferation, because we have to define invasion now. What does invasion mean? Because if we see invasion, this is cancer. This is the rule of cancer. It invades. So if these downward proliferations of epithelial tissue were too pointed, this could be an early sign of invasion. Okay, so this is the dysplastic epithelium. You see here, local excision. If you see this mammography, I think it's a mammography, breast, yes. What do you think is indicative of malignancy? Have a look at this mammography. As you see it, what of those we talked in the beginning of the lesson is suspicious that this lesion is malignant? What do you think? Come and show me. No, you come to the mouse. The mouse. What's the problem here? Show me the lesion. And you'll have all the time to study the slides. They are already uploaded. All right? And study.
Maybe these.
I'm not so sure. That's something in the lesion. Do you remember how we defined malignant lesions? What are the hallmarks of malignancy? One is atypia of cells. We cannot see that. That's a radiographic presentation. The other, what's the other? Invasion. So how can we define in a lesion if it is invading, what do you think that the contour, the surrounding, the contour of such a lesion should be? Should it be smooth, expanding, like a benign neoplasm, or should it be infiltrative, like a malignant neoplasm? So, show me the contour of the lesion. The contour. Round the lesion. Round the lesion. The contour. This. Is it smooth?
I know.
You see that? No, of course. So it has signs of malignancy. Of course, it will be excised, and we'll have a look at the microscope to define malignancy as well as cellular atypia. All right? So if you see a tumor lesion with an irregular contour, such as this one, this is indicative. Indicative. Not characteristic, indicative of malignancy. All right? That's simple.
What else could have been if it's not malignancy?
What could it be? Inflammation. Perhaps it could be an inflammatory lesion, who knows? However, if you see such a lesion and you touch it and it is not movable, you cannot move, see that it is some sort of attached to the surrounding tissue, and you cannot define its margin by touching it, that means it probably infiltrates surrounding tissue. Because if it's a benign lesion, it will be like a lump, and you'll see a smooth contour, not being so closely opposed to surrounding tissues. And that's why it would be very easily excised by surgery. If it's benign, you open and take it out. It does not invade surrounding tissues, so it is not necessary to clear the area on a free margin of tissue. All right? So this looks malignant. Yes. Yes, and the same is here. See how deep this lesion is in the breast? This is from macroscopy. Yes, please.
So I didn't understand how we differentiate between high-grade and low-grade dysplasia.
Yes. If you have a squamous epithelium, as the one we see, the more basic criterion is the thickness of the epithelium, which is affected by dysplastic cells. If the dysplasia is shown in parabasal cells, after the basal cell, it's the basement membrane, basal cells, parabasal cells. So if it is within 1/3 of the epithelium, it's low grade. If it increases in the 2/3 of the epithelium or in the full thickness of the epithelium, it's high grade. Or in situ carcinoma, if there is no sign of maturation, of the epithelium superficially. So this is another malignant lesion. You see, ill-defined. Have a look at the margin, please. Have a look at the margin. You see how ill-defined it is? And it's very scirrhous. What does scirrhous mean? Many tumors, not all of them, many malignant tumors have a specific alteration in their stroma. They cause desmoplasia, and in some cases this leads to scar, a scarry tissue. So this can make the tumor rather solid and hard on palpation because it has a scirrhous stroma background. So, and this patient had a serum parathyroid hormone related peptide and serum alkaline phosphatase levels elevated. So in a cancer patient, we said that malignant neoplasia is not a local disease, it's a systemic disease. And these findings reinforce this concept. Why? In some tumors, the tumor cell secrete some agents which act like hormones. And you see, these are called paraneoplastic syndromes. They do not have to do with the local spread of the tumor, but to what the malignant cells potentially secrete. And this secretion reaches the circulation, and we have systematic effects. For example, if the tumor releases a peptide which acts like parathormone, what will the patient have in his blood? Increased calcium. But this will be from an abnormal source, not from the parathyroid, but from what the malignant cells secrete. So, in some tumors, we have systemic syndromes related to what the malignant cells secrete. These are called paraneoplastic syndromes. And if we have, in the biochemical analysis, elevated alkaline phosphatase, you remember in biochemistry, what does the elevation of this enzyme mean? Alkaline phosphatase. It has two isoforms. One has to do with cholestasis in the liver, and the other has to do with the activation of osteoblasts in bone tissue. So, if in a cancer patient we see alkaline phosphatase increased in the biochemical check, we should check the liver if what could be in the liver that impedes normal cholerythrin circulation? Metastasis. Anything that blocks the normal circulation of the cholerythrin from the conjugated form from hepatocytes that leaves the liver to go to the bowel, if we have some sort of a stone or a metastasis or another tumor which could be benign, then we have a raise on alkaline phosphatase. So you have a cancer patient with a raise on the alkaline phosphatase, have a look at the liver with ultrasonography. A tumor might be there, which could be metastatic in the present patient. About the bones, the same thing. You know that malignant tumors invade the bones. This is distant metastasis, end-stage disease. Yes. If we have osteolytic lesions and the bones break, what will be increased in the patient's serum? If we have a fracture, calcium, yes. These are the most common metastases. They are osteolytic metastases. However, in some tumors, such as the small cell lung carcinoma, when metastatic cells reach the microenvironment of the bone, they activate osteoblasts and a newly formed, poorly structured osteoid is formed. These are osteoblastic metastases. In such cases, the activation of osteoblasts, which enzyme in the serum will it raise? Which enzyme, if the osteoblasts are activated? Alkaline phosphatase again, but not the same isoform as the liver. Another isoform, having to do with osteoblastic proliferation. Yes?
Can you explain what does alkaline phosphatase do?
What?
What does alkaline phosphatase do? Can you explain again? I didn't understand what does it do.
It's an enzyme from the biochemical check. You see it. You have the biochemical set, the level of alkaline phosphatase. If it is increased, you have to look at the liver, depending on which isoform of the enzyme is increased. You have to check the liver or the bones. It's not always from metastasis. There is a metabolic disease of the bones called Paget's disease, which also activates osteoblasts. However, when alkaline phosphatase is increased, you have to check these things. Next.
Professor,
Yes.
can you show again on the picture where is the lesion?
Where is the lesion? Yes, of course. Here is the lesion,
Yes, but why?
and have a look at the margin, how irregular it appears. Have a look. You see? Why is it irregular? Because it invades the fat tissue of the breast stroma. Okay? Scirrhous mass means a tumor which has an acellular pink staining, eosine staining, substrate, stroma. Cirrhosis is in the liver when the architecture is distorted throughout the liver and we have nodules. This is cirrhosis of the liver. That we are talking here in malignant neoplasm is scirrhous stroma. Yes. What's the problem with this scan? What's the problem with this scan? Have a look. Yes, it's back pain from a 66-year-old man, and we have these lesions. These are multiple hematogenous metastases, and which organ is the most probable to give them in an aged man? And it spreads through the bones. You do not have other symptoms apart from pain in the bones. Which organ? It's the most common cancer in men. The most common cancer in men. Not the most fatal. Prostate cancer. So, if you have an old man and he says, I have a pain in the back, do not hurry to define this as osteoarthritis. It could be, of course, it could be osteoarthritis. However, it could be metastasis from a primary prostate carcinoma. So, you have to check the prostate.
Is this treatable? Is the bone cancer treatable?
All these, foci here, are cancerous cells.
Yeah, but is it treatable? Can be treated?
Yes, of course. Yes, it's treatable with androgen deprivation, because organs who are targets of sex hormones give the possibility to the oncologist to control them by blocking the stimulus, the hormonal stimulus. As far as prostate cancer is concerned, we have to block androgens. As far as breast cancer and gynecological cancer is concerned, we have to block estrogens.
And there are different types of cancers, like there are some breast cancers that are not estrogen positive.
Yes, on time. Next semester, we'll have a look at some of them which are not estrogen dependent. Yes, there are.
This is the same for the prostate.
Due the course of the disease, sometimes a hormone-independent clone emerges, and this cannot be treated by hormone manipulation. All right? So where are the cancerous cells here? Where are they? Histology. What is this in the bone? What are these cells in the bone? What are they? It's histology. Osteocytes. Yes, they are in the osteoid matrix. In the matrix. Have a look now at these cells. Are they normal cells of the bone marrow? No. Why aren't they normal? What do they form histologically? What do they form here? What structures are these? Yes, please? In the bone, there are no such structures. But what structures are they? Can you define them histologically? Because this is a sign of differentiation. That means we have a neoplasm, we have to look at the differentiation and decide where it comes from. So what are these structures? Who can define them? Have you got the grades in histology lesson? Excellent. You had all excellent grades. All right, no problem. If you define it here, I give you a pathology pass. Pathology pass. You go to histology, you say, what have you got? 7. No, have +2 from pathology, you get 9. So, what are they? What are these structures? Do you want me to describe them? Yes, of course. In the center, have a look here. They are empty. You see? So what is this called? If we have a structure and it's a gland. It's either a gland or a vessel. The vessels are lined by endothelium, flattened cells. Flattened cells. The glands are lined by, what are the glands lined? What are the glands lined by? Epithelium tissue. So, it's a malignant neoplasm invading the bone, which has differentiation of glandular epithelium. As it is a malignant neoplasm deriving from epithelium, it is called a carcinoma. Attention, carcinoma is the malignant neoplasm of epithelial origin. If it is of mesenchymal origin, fat cells, fibroblasts, muscle cells, it's a sarcoma. If it is of lymphoid origin, is a lymphoma or leukemia, if the cancer cells circulate in peripheral blood. So this is the terminology of cancer. There is the general term cancer, which includes everything, but from a pathologic point of view, they are separate lesions. Carcinoma is what derives from epithelial tissue. We saw glandular epithelium. Since we have epithelium, it's a carcinoma, and since it is of glandular type, this is an adenocarcinoma. So where it may come from? It may come from tissues with such epithelium in their mucosa. Which tissues have glandular mucosal lining? Which organs? Yes, which? Yes, the large bowel, the small bowel, the stomach, glandular epithelium. If we have a woman, the uterus, glandular epithelium. Or the cervix, glandular epithelium. What else? The prostate, it does not have a mucosa, however, it is epithelial tissue of the glandular type. In the prostate, parenchyma. So, if we have such metastasis, you'll think, which organs have such type of epithelium, and try to look where the primary lesion, the primary cancer has developed. Yes? The pancreas is of epithelial origin. The exocrine pancreas is of epithelial origin. It forms acini, and it has ducts. Ducts are glandular epithelium. Why? What is the difference? When we say ducts, the breast, the salivary glands, the pancreas, it has glandular epithelium that looks at the lumen. These are the lumen cells, but it also has another layer in ducts which are called myoepithelium, because all organs who secrete something need the myoepithelia to push the secretion as far as the pancreatic tissue is concerned to go to the bowel, to fatter. Okay? All right. And another image. If we have such a lesion in the liver, this is an autopsy specimen, How can it be justified? How can it be justified? What are these? Some of them are necrotic. That's why You see this umbicylation here. You see here? Some of them are necrotic. What will the patient with this liver have increased in his serum? What? Of course. Even if one of such lesions was present, it could raise alkaline phosphatase. However, due to the multiplicity of such lesions, how can they be justified? If you see this lesion in the liver, what is the logical macroscopic diagnosis? Multiple hematogenous metastases, possibly from the bowel, the colon, the stomach, the neighboring pancreatic tissue. So this is end-stage disease. Yes?
Why does it have to be metastasis and the malignancy be developed here and metastasis in its own organ? You have the malignancy developed in the liver. Can it just metastasize?
In that case, it would not be metastasis, it would be synchronous or asynchronous hepatocellular carcinoma development.
How do we know it's metastatic?
We'll have a look at the microscope. Theoretically, this could be a hepatocellular carcinoma of primary origin with multiple foci. The most possible is to be metastasis. However, you'll take the section and have a look on the microscope and see what it is compatible with.
What would be the difference microscopically?
Don't be patient. In due course, you learn that. In due course, be patient. All right. So, those were the neoplasia images for today, and we'll go on in about, I think, 2 weeks. Okay? You can have a look at these slides and everything that is uploaded on your e-class. All right? Thank you very much. Yes, please.
Usually the malignant neoplasias secrete or don't secrete catecholamines or something.
To make paraneoplastic syndrome, it's not that often.